So I'm going to start with a bit of a kind of a spoiler alert. There's no single best way to do a process evaluation, and this was the conclusion of Grant and colleagues who did a systematic review a couple of years ago of process evaluations done alongside cluster randomised control trials. So I'm definitely not going to go and tell you the best way to do a process evaluation. What I'm going to try and do is just give you, I suppose, pointers towards some of the good guidance that you can look at, and I'm also going to talk about our own experience of doing a process evaluation alongside a pilot trial. So, as I said, there's no single best way. How you do a process evaluation and what it looks like is going to depend on your research questions. It's going to depend on the overarching aim of your RCT. It's also going to depend on when you're doing the process evaluation. Are you doing a part of a pilot trial like we did? Are you doing it alongside an effectiveness trial? All this is going to make a difference in terms of what your process evaluation looks like and the data you collect and how you do that. So, again, no single best way, but there is lots of guidance, and thankfully in 2015 the MRC came out with this guidance on process evaluation alongside evaluating complex interventions. And I suppose that's just one thing to flag. I suppose I'll come to that in a second. I'm kind of framing this from the point of view of complex interventions, and so that's kind of the area I'm familiar with, and less so about clinical trials, but more so about kind of health service type interventions or public health interventions, which are complex interventions, and I'll talk a bit about those in a minute. So that's how I'm framing this talk, and I suppose a lot of the guidance I'm pointing to is kind of couched in that area. So today I'm going to talk about what a process evaluation is and why you might conduct one, and its purpose at different stages of that kind of complex intervention development and evaluation cycle. I'm going to talk about what's involved in a process evaluation, and I'm going to talk through data collection, and I'm going to reflect on our own experience of collecting data as part of the IDEA's pilot trial, and then end with some considerations and reflections and lessons learned from that. So again, as I said, talking very much about complex interventions, and so by complex interventions I mean kind of health service type interventions that have multiple interacting parts. They might be targeting different organisational levels, they might be targeting different stakeholders. So like the pilot trial that we did, the IDEA's pilot trial, we were targeting both professionals and also patients, and so that I'll talk a bit more about what that intervention involved in a minute. And so when we're talking about process evaluations, we're talking about any studies that are running alongside or following intervention trials, which are collecting data to tell us things about how the trial went, how the processes worked or didn't work, to explore things like how our intervention actually worked. And then it also might help us explain why we see variations in effectiveness, or what are the kind of factors that might be the reason for that. So why are they valuable? I suppose the previous sentence probably gave you a hint towards that, but I really like the sentence or the statement by Grant and colleagues, where they said process evaluation is really trying to open the black box. So you're trying to get under the hood of what's happening, and often that can be to try and figure out how your intervention is working. Is it working the way you thought it would work, or did it not work, and why is that? Will it work as well in a different context? So often, we trial an intervention in a certain context, and then we want to move it to a slightly different context. And if we don't understand how our intervention is working in one context, it's very difficult to transfer it into another context and see the same outcomes we saw in the first context. And when I'm talking about context here, often I'm talking about different health service settings, or even as simple as a different GP practice. So you do an intervention trial in one type of intervention or GP practice, then you try and replicate that in another GP practice, and it doesn't work the same way, and you need to understand why that happened. So process evaluations can help us determine why an intervention failed unexpectedly, and also why it has unanticipated consequences, and it also gives us important guidance on how we might optimise our intervention. So I kind of alluded to at the start, there's no best way to do a process evaluation, or single best way to do a process evaluation, and a process evaluation will have different functions at different stages of this life cycle of developing and evaluating complex interventions. So the MRC, the Medical Research Council guidance, some of you are familiar with that, they kind of suggest that you start with feasibility testing, and I know Declan's going to talk about that tomorrow. That you start with feasibility testing, then you move to your effectiveness trials, and I suppose when you're at the stage of feasibility or pilot testing, like we were with the IDEA's pilot trial, what you're interested in there is, often the feasibility of your actual trial procedures, your trial design, what you're planning to do as part of the trial. Is it going to work if you upscale this to a full trial or an effectiveness evaluation? You're also interested in how acceptable those trial procedures are to the people involved in the trial, in our case the professionals and the patients. You're interested in obviously the feasibility and the acceptability of the intervention. Is the intervention you've come up with, is it even acceptable to patients that you're going to be interacting with, or are going to receive the intervention? You're also interested in things like barriers and facilities to implementation, and things like adaptation. So are people going to adapt the intervention to improve its fit with context? All these are things that you'd like to learn potentially as part of a pilot test and part of your process evaluation alongside that. During effectiveness evaluation, you're scaling up. There's maybe more scope for there to be variation in context, variation in participants, and you're probably trying to understand how that variation, influences implementation, how it actually leads to differences in maybe the outcomes you see during that trial. If you're doing a post-evaluation post-evaluation implementation and you're doing a process evaluation alongside that, you might be more interested in questions around how to sustain or how to deliver the intervention with fidelity in different contexts and how to sustain that intervention. I'm not going to go into policy trials and natural experiments. I know that they're kind of mentioned in the MRC guidance as another type of evaluation that you can do a process evaluation alongside. And the main concern there, I suppose, is how you're going to deal with the fact that you're not in a randomized controlled trial sort of environment. It's very difficult to kind of figure out how study implementation in your control versus your intervention if you do have control sites. So that's just to give you a sense of the different functions a process evaluation might serve at different stages of that life cycle. So when we talk about how to conduct a process evaluation, there's lots of different systematic reviews out there, and part of what I want to do today is point you in the direction of good literature that you can look at to learn more than I can tell you. So there's two really good systematic reviews out there, a recent one by French and colleagues and the Grant and colleagues review I pointed to earlier. And I suppose the conclusions of those reviews were, particularly the Grant review, is that they're quite inconsistent use of the term of process evaluation. So often people might do what looks like a process evaluation but not label it as such. And Grant and colleagues also report a lot of variation in what people aim to do, the types of methods they use, the timing of the process evaluation and how they report it. And part of that is reflecting the different aims of the RCTs that they're running alongside, but it's worth looking at those reviews. You want to get a sense of the types of things people do as part of their process evaluation and how they vary. But I suppose just to come back to the MRC guidance, because we do have this excellent guidance out there on process evaluation it's a very long document. I would advise you to have a look at it. It goes through the whole process. It tells you what to consider at each stage. It can tell you a lot more than I can tell you. But in that, they give you a sense of what you should be looking at as part of your process evaluation. Again, there's no single best way, but there are certain domains that you should be trying to look at during a process evaluation. So they suggest that you should be looking at implementation. You should be trying to study what is being implemented as part of your trial and how is it being implemented. You should be looking at mechanisms of impact. So does delivered intervention actually, how does it produce change? And then you should also be looking at context. So how does the context you're implementing or delivering your intervention in, how does that affect implementation and outcomes? So they suggest kind of organising your process evaluation around these three domains. So what I'm going to do is, rather than trying to cover each of them in detail, I'm just going to give you a sense of things you could consider falling under each of those domains, and also touch, I suppose, on what we did as part of the IDEAS pilot trial as well. So in terms of understanding context, so in the MRC guidance, obviously there's lots of different ways you can define context and lots of different frameworks you can use to kind of characterize context. In the MRC guidance, they refer to this definition by Lynn and Steckler, where they say the context is any aspects of the larger social, political and economic environment that might influence intervention implementation. And really, I suppose you should be trying to collect data as part of your process evaluation on context to help you to interpret the outcomes that you see. So some kind of simple thing is, for us, I suppose in the context of the pilot trial that we were doing it in GP practices. Now, we didn't do a readiness assessment, and on reflection that would have been something we could have done. But you might try and look at the readiness of your implementers of your sites to actually implement the intervention you're proposing. So they have, what kind of pre-existing culture do they have, what kind of pre-existing skills, what are the organisational norms and resources they have in their context that might potentially influence how that intervention is delivered during the trial. It can be helpful to draw on some existing framework to guide your understanding of context. There's a lot of frameworks out there, and I would suggest looking at the review by Lisa Rogers and colleagues from UCD. So she's done a huge amount of work around how you characterise and how you define context, and she has a systematic review which pulls together all the different frameworks that are out there. Now, it's situated kind of in the implementation literature, but it is useful in terms of just knowing what's out there to help you to characterise context and what types of things to be looking at. So that's just going to a brief overview of context. And the next, I suppose, domain that they talk about in the MRC guidance is implementation, and what is implemented and how it's implemented. So they suggest that, I suppose, under this domain you should be thinking about looking at things like dose, fidelity, so the consistency with which the intervention is delivered, things like adaptation, so has it been altered in any way to improve its fit with the context, whatever that might be. Things like reach, so has the intervention actually reached the audience or the population that it was intended to interact with in the first place, And then implementation process, so how is delivery being achieved? So what are the resources and things, skills and things that needed to actually be in place for implementation to happen? So one thing they do say in the RSA guidance is that there's really kind of not agreed consensus on how you divide up these different components or how you study implementation. Like they suggest looking at dose, fidelity, adaptations, reach and implementation process, but even in the implementation science literature, sometimes the words implementation, adherence, fidelity can be used interchangeably. There's a lot of different ways of breaking down how you study implementation, and so they don't kind of say that you have to ascribe to this specifically, but they do suggest a whole range of different frameworks that you can draw on to help you to study implementation as part of your process evaluation. The other thing they flag, and it's worth mentioning here, is that, you know, with a big complex intervention with lots of different components, the IDEAS trial probably isn't the best example of that because we did have multiple components but not a huge amount to deal with. But if you're looking at a very complex intervention with a lot of different components, studying implementation of each component as part of your process evaluation really intensely may not be feasible. It may not, you know, you may not have the resources for that. So you may have to decide, are you going to focus on the core components and study those as part of the process evaluation? Or are we going to kind of focus in on those in particular? So the reason I've kind of had an asterisk beside fidelity is because fidelity is really, really important, and you need to consider how you're going to know that the intervention you delivered has been delivered with fidelity during the trial, because if you don't know if it was delivered the way it was intended, then you don't know if the results you ended up with at the end were because it was not delivered properly or was delivered differently. You might also see an effect because people ended up tweaking things because it was a really kind of ineffective intervention. They just tweaked it and made it ineffective because they changed the way it was being delivered. So you really need to understand what's happening. That's what the summary is in terms of fidelity. You need to be able to know, did what you planned to happen in terms of your intervention, did that actually happen? And so I kind of said what I was planning to say there. So the other thing to flag about fidelity is the difference between fidelity and adaptation. And I know there's kind of a lot of, you know, reading and conversation that you can look into this in more detail, but I suppose fidelity is looking at the consistency to the intervention as planned. Adaptation is looking at, as I said, kind of alterations to the intervention that might kind of be improvements or even beneficial. And so I suppose a decision for you to make in terms of your process evaluation is, first of all, how are you going to characterize the two of these things, and then how are you going to make a decision on what's a core component that actually needs to be delivered as part of your intervention for it to work, and what are the things that are, you know, things that can be tweaked locally at a site to improve how, you know, improved delivery. And so that's just a kind of open question to put to you to kind of consider these two things and how you're going to actually study those as part of your process evaluation. I'll talk a bit now about how we did that in terms of the IDEAS trial. So I'm not going to try and cover every type of framework that you can use to help you study implementation as part of a process evaluation, but one thing we did draw on was the Proctor and colleagues implementation outcomes framework. So that helped us just to kind of structure our process evaluation in terms of what we were aiming to do. So we were trying to answer questions around appropriateness, acceptability, feasibility, reach, fidelity, and then also cost to do a kind of partial economic evaluation as part of the trial. We also drew on a fidelity framework by Belling and colleagues, which organises fidelity by intervention design, training, delivery, receipt and enactment. There's other fidelity frameworks out there, and the one they refer to in the MRC guidance is the conceptual framework by Carroll and colleagues, which not only suggests that you should be thinking about adherence in terms of content and frequency of the intervention of delivery and duration of coverage, but also suggests that you should be thinking about moderators of fidelity. So things like how a participant responds to the intervention may affect its fidelity, and so they prompt you to consider things like that if you use that framework. One thing we used to help us to characterise adaptations was this framework, which has been recently expanded to now be applied specifically to implementation strategies. So if you're not looking at evidence-based intervention, you're looking instead at implementation strategy, and that's what you're trialling, then maybe Frame IS is a more appropriate framework to use to help you to characterise adaptations. And that was really useful just in terms of getting our head around the different things that people had done at the sites to adapt the intervention that we gave them to deliver. I'm not going to talk about these, but there's a huge amount of work out there in terms of how do you track adaptations, particularly in the implementation science literature, so it's worth looking at those if that's something you're particularly interested in. And again, just to refer to the MRC guidance, they have this really nice diagram where they give you all the frameworks and theories, well, not all the frameworks and theories, but a selection of frameworks and theories basically that could be used to help you to understand the context, the implementation, the mechanisms, and impact domains. So just in terms to finish up, I suppose, in the MRC guidance domains, they also talk about being able to understand mechanisms of impact. So how does your delivered intervention actually produce change? And so this is really, really important. It's really important to be, I suppose, thinking about your process evaluation and how it helps you to understand the causal assumptions underpinning an intervention. And again, this is kind of taking it out of the drug clinical trial sphere and more into the complex intervention sphere where there's multiple interaction parts and they're kind of system level interventions. But you need to, I suppose, at the start kind of be clear about what your causal assumptions are and then decide whether you're going to actually collect some data to test that. And if you understand how your intervention works and you can kind of, flesh that out through a process evaluation, then that'll help you transfer it to another context or think about how you're going to deliver this in another context. And so there's been a lot of interest in the last few years in theory-based evaluations and also realist evaluation, and particularly realist evaluation going alongside trials. And so realist evaluation is taking it from a different angle. It's kind of saying the interventions work by being put into introducing a mechanism that's suitable to their context, so that these certain mechanisms fire in a given context, and they say that how an intervention works is very contingent on time and place. And some of the kind of background and the I suppose what the realist evaluation is positing kind of runs contrary to the evaluation design, and there is quite a lot of discussion around that that's worth reading. I've done a realist evaluation, but not alongside a trial, so I can't probably speak to that, but I will point you towards a paper by Rachel Gold and colleagues, which has a nice protocol setting out how they're going to do this pragmatic stepwise trial. It's a tailoring intervention, or tailored intervention, and they're going to do a realist evaluation alongside it. So that's a nice example of how you might consider doing a realist evaluation alongside a trial. So one thing in regard to mechanisms, as I said, you need to explicitly state what your assumptions are at the start. How do you think your intervention is going to work, and then are you going to test data to collect those assumptions? One way you might do that is come up with a logic model. I don't have time to go into logic models, and I'm definitely not an expert in logic models, but I will point you to some useful resources on logic modelling. And this is a useful tool just when you're developing an intervention, even when you're kind of engaging with stakeholders and making sure everybody's on the same page in terms of how your intervention is supposed to work. A logic model can be really useful. I'm not expecting you to read through all of this, but just to flag for the ideas trial, we did come up with a logic model. By no means the best example of a logic model. We definitely could have articulated how we expected the intervention to work a lot better ourselves. But we did use it to kind of flag some potential kind of moderators or things in the context, like the practice location, the staffing levels that we thought might kind of affect fidelity and how the intervention was working. So I'm not going to talk about theory-based. How am I doing for time? Because I wasn't going to talk about that. I might. That's perfect. I might skip over theory-based evaluation, but we can always come back to it. I just left in the slides there as a nice example of theory-based evaluation, because the pilot trial that we did and the process evaluation is probably, is not necessarily a good example of that, and it wasn't theory-based. So I'm going to move on to data collection. So the MRC guidance advocates for mixed methods. All of you are familiar in the room with qualitative versus quantitative methods, so it advocates that you should be using both to kind of conduct your process evaluation. You need to think about things like what data needs to be collected. Obviously, that's fairly common sense. Importantly, also think about where you're going to collect it from. So for the pilot trial that we did, we collected data for our process evaluation from intervention sites only. Part of that's to do with kind of resourcing, but it's the kind of decision needs to be made. Are you collecting process evaluation data from your intervention and your control sites, or just the intervention sites, or just a sample of intervention sites? Who are you collecting it from? How are you going to collect it? That's obviously the data collection method. When are you going to collect it? Are you going to collect it throughout the trial? Are you going to just collect it at the start or the beginning? Beginning or the end? And then who is going to actually collect the data? So is it going to be you as the researchers, or is it going to be the people involved in implementing the intervention? So I'm going to move on just to illustrate some what we did, I suppose, in terms of data collection. I'm going to use the IDEAS trial to illustrate that. So the IDEAS trial was a cluster-randomised pilot trial over 6 months. It had an embedded process evaluation, partial economic evaluation, where we just kind of costed the intervention. And the aim was to investigate the feasibility of an intervention to improve the uptake of the national diabetic retinopathy screening program, Retina Screen, and it was delivered in primary care. So without kind of going into too much detail, as I said at the start, there was professional kind of level elements where we were asking professionals to engage in an audit of their retinopathy screening uptake. Asked them to put an electronic prompt to remind them to remind patients. There was reimbursement for them to engage in this practice, and then we also provided kind of ongoing support with audit and with delivering the intervention. Then there was patient-focused elements, which were practice-endorsed reminders delivered in a variety of different ways, in person, by phone and letter, following a script. And then an information leaflet that was structured really around targeting what we knew were the key barriers from the literature, so key attitude and knowledge barriers. So there was patient and professional level elements. And I suppose I just highlighted here our kind of process evaluation type objectives. So as I said at the start, there's different reasons why you might do a process evaluation and different function. It might have different functions depending on where you are in kind of that life cycle of evaluation. So because it was a pilot trial, we were really interested in those questions around feasibility. How feasible were our trial processes to actually conduct? So was it feasible to recruit a sufficient number of practices? Was it feasible to retain practices? Was it feasible to collect the data? We were all interested in our data collection processes. Were they acceptable to the staff who were involved in the trial? And then I suppose we were interested in the feasibility of the actual intervention itself and the acceptability from the perspective of patients and the professionals. So what we did, we had interviews with staff and patients just from intervention practices. I should have said at the start, this was a very small pilot trial. We had 4 intervention practices and 4 control practices, very much just to see could we do this and whether the intervention was feasible and acceptable. So we did interviews with staff and patients from intervention practices. We also did questionnaires with staff from intervention practices. There was research logs which were populated by myself through engagement with intervention practices. Kind of trying to gather things like how long it was taken to do different things, or who was being assigned to different tasks, what kind of resources they were using. And then we also drew on the practice audit data. So an audit was part of the intervention, but it was also a source of data for us for the process evaluation. So I'm not going to go through each of these tables in detail, but I just wanted to kind of show you, I suppose, that one thing we did which helped us kind of clarify why we were collecting the data and what type of data we were collecting is we mapped all our data onto what it could tell us in terms of that proctor implementation outcome. So the audit data was telling us things about the reach, the fidelity of the intervention. So we were getting staff to document things like how many people they gave the intervention to, how many people responded. I'm not going to go into all the detail there, it's in the slides. In terms of the research processes, this was telling us a huge amounts of feedback I've been getting from staff. It was telling us about how acceptable it was, whether it was feasible, how much it was costing. Again, kind of going on to the researcher phone calls, that was again telling us information about how feasible it was, whether it was, they were delivering the intervention as intended, how much it was costing, and there's a huge amount of detail there in terms of everything we were trying to pick up through those phone calls, and I'll come back to that in terms of how feasible that itself was. And then at the end we had staff questionnaires, as I said, and interviews, which were telling us kind of about the acceptability and feasibility and fidelity. And so in the interviews we were asking, So in the interviews we were asking things to try and kind of get a sense of how people are interacting with the intervention components, what they thought of the intervention, what they thought of the trial processes, and any barriers and facilitators to actually delivering the intervention as part of the trial. So I'm going to finish up with just some considerations. So I've gone really quickly over the ideas pilot trial, so I'm happy to kind of go through that if anybody has more questions. And there's also the papers at the end that you can read, which have a lot more detail, have more detail on these tables. One thing I will say is don't over collect data. Obviously what really helped us is being able to clear about what piece of data was telling us about what outcomes. We were clear why we were collecting each piece of data and what was actually going to be used for, and that helped us at the end as well in terms of integrating all those data sources together. You have to think about, I suppose, what you can feasibly collect, and there's always a risk of overburdening participants. And I did feel, I suppose, with this trial, because staff were collecting the audit data, they were also engaging with myself to populate research logs about what they were doing. That was a lot of burden on already busy GP practices, and that was kind of a big learning for us in the sense that ideally we would have had a researcher on site doing that piece of work for them, but we couldn't do that. And so for me, there was a lot of back and forward practices trying to kind of fill in gaps in the data, trying to help them along with the audit process. And I suppose that was the major reflection for us, is that if we were doing this as a full-scale trial, we would need to make that a lot easier and a lot more automatic, and I know people have already alluded to that, so that was a big learning for us. It's good to think about, can you use routine data that's already been collected? Do you have to go out and collect a whole bunch of other data as part of your process evaluation? Could you do something like embed a process evaluation type question into an outcome questionnaire that people are already filling out as part of the trial? These are kind of considerations for maybe cutting down on the type of data and the level of data that you need. I'm not going to talk through that table. That was just showing how we mapped all our data onto different research questions to make sure we were definitely collecting everything we needed. So I'm going to probably wrap up there. One last thing I was going to say was just one thing is to consider is timing and competing priorities. One is kind of obvious. The other one was kind of yeah, I'll just final sentence. So I was going to say that so one thing we realised was a 6-month trial. So we were doing a process evaluation, we were doing a trial. We were also trying to get people to go to the screening programme. So one thing we found that happened with a couple of people is the process evaluation materials, the consent forms, the information sheet for that, inviting them to take part in the process evaluation interviews was sometimes coming at the same time as the materials from retina screen if somebody had decided as a result of this intervention to attend the screening programme. And there was a couple of people I interviewed who were very confused about the two. And that I think speaks to the point of having really clear in your information leaflets, but also thinking about the timing. Are people going to be bombarded with a lot of information from the trial, from the process evaluation, from other things going on all at the same time, and how are they going to distinguish that? So I just wanted to kind of finish on that point. And to wrap up, there, obviously, as I said at the start, there's no single best way to design and carry out process evaluation. Hopefully I've given you some resources to think about and some reflections as well. So thank you.